Hello, class. This is Dr. Crystal Nagallo, adjunct faculty with Arizona College of Nursing. We are going to cover Chapter 11 of Anatomy and Physiology in this video. We will discuss concepts of the nervous system, specifically focusing on the brain. We'll briefly discuss the 12 pairs of cranial nerves. And then we'll move into the autonomic nervous system and end off with the special senses today. So building on the concepts discussed last week, the central nervous system includes the brain as well as the spinal cord. These two organs comprise the central nervous system, and it's central for a reason. They are critical for integrating a lot of the nerve signals that travel throughout the body. So the brain is divided into four main parts, if you will. They're listed for you on this slide. The brainstem, diencephalon, cerebrum, and cerebellum. When we look at an image of the brain, the cerebrum is what we most often think about. And the cerebrum is divided into several lobes named after the closest cranial bone it is located next to. The cerebrum is most responsible for intellectual processes as well as the processes that regulate emotions. The cerebellum is often referred to as the mini brain because it literally looks like a small brain. The cerebellum is what I look to determine which part of the brain is anterior versus posterior. The cerebellum will always be located posterior to the brain. The cerebellum is really important for regulating coordination. So when the cerebellum is damaged, or if there are degeneration processes that are occurring in the cerebellum, patients easily start to lose posture as well as their sense of balance. That leaves us with the diencephalon. The diencephalon is home to some structures we've talked about already, especially in the endocrinology unit. So the diencephalon will include the hypothalamus. Also located in the diencephalon is the thalamus. The diencephalon is really important in maintaining homeostasis. And last but certainly not least, the brainstem, which is comprised of three segments. The brainstem is the connection between the brain and the spinal cord. The brainstem has three sections, as mentioned already. And those sections are known as the midbrain, the pons, as well as the medulla. The midbrain, pons, and medulla are responsible for many of the processes that are vital to life, including breathing, heart rate, as well as our reactions to what we hear or what we see in our environment. So here is a schematic of the brain. The lobes of the cerebrum, all of this is cerebrum right here, are color-coded to help us differentiate between the different lobes. Here's the cerebellum located posteriorly, and here's the brainstem, which will eventually connect the brain to the spinal cord, which descends inferiorly. What we are not seeing is the diencephalon. The diencephalon is located superior to the midbrain, and so it would be behind this temporal lobe if we were able to retract it to the side on this slide. Now, considering how important the brain is, there are 3 layers of protection known as the meninges. These are specifically known as the dura mater, arachnoid mater, and pia mater. The meninges are heavily embedded with capillaries and blood vessels. And so many of the red flag cases, emergent cases that are of the utmost priority in the urgent care emergency room setting have to do with whether blood vessels in the meningeal layers are broken. This would lead to bleeding within the meningeal layers and eventually cause some stress on the brain, which would clearly be problematic in the long run. Of course, superficial to the meningeal layers are the cranial bones themselves. Hopefully this is reviewed from Bio 201. These are the cranial bones known as the frontal bone, the 2 parietal bones, the 2 temporal lobes, and the posterior occipital bone. Circulating throughout the entire central nervous system is a fluid known as the cerebrospinal fluid. This is the fluid that we are collecting in the lumbar puncture, also known as the spinal tap. The cerebrospinal fluid has a certain flow. They are made in the ependymal cells of the ventricles in the brain, and they drain through certain foramen. There is a right ventricle and a left ventricle. They're specifically known as the right and left lateral ventricles, so that they can be distinguished from the right and left ventricle that we talked about with respect to the heart. These lateral ventricles will drain into a third ventricle, numbered for a reason, through a foramen known as the interventricular foramen. The ventricular system that circulates cerebrospinal fluid can be a conversation in of itself, which we will leave for a different day. What's most important to take home right now is that the cerebrospinal fluid is able to circulate throughout the entire central nervous system. This includes the brain as well as the spinal cord. We're going to hone in on the functions of the brainstem now. And so starting with the medulla oblongata, often abbreviated as simply the medulla, there are several tracts, nerve system tracts that connect the peripheral nervous system to the central nervous system. This is what we mean by ascending and descending tracts. If you recall, the pattern in which sensory stimuli is then converted into a motor signal, that will dictate the ascending and descending tracts. It has to do with whether the signal is going from the sensory nerve receptors up in an ascending fashion to the brain for analysis. And then the descending tracts would carry nerve signal from the brain after it's analyzed and then down in a descending fashion to the peripheral nervous system that will then control motor function. There's a specific portion of the medulla oblongata known as the reticular formation. I bring this up because this is often referred to in the literature as well as studies. This is what we know to most control our sense of consciousness. There are many reflex centers that are also found in the medulla oblongata. And so one of the concerns that we have for patients who undergo whiplash, a severe case of whiplash because of a motor vehicle accident. Sometimes, depending on where the vector of impact was, as well as the severity of the impact, the medulla oblongata is damaged, and this can significantly decrease reflex rates in patients because the reflex centers are found in the medulla oblongata. Next are the pons varolii, often shortened and called the pons. While the pons also connect the spinal cord to the brain, what I would like for you to take home here is that the pons will help control breathing. When we talked about the respiratory system in Bio 201, we addressed how breathing is very much is driven by a involuntary, if you will, method. While we can control breathing, if we weren't thinking about breathing, we would still breathe anyway. And that's because of nervous system function, specifically the function of the pons in the brainstem. The pons, for as long as they're alive and thriving, they will help make sure that we are bringing air into our lungs and exhaling carbon dioxide with every breath. Third and final section of the brainstem is the midbrain. There are several reflex centers in the midbrain, specifically the dorsal tectum. The midbrain is the most superior aspect of the brainstem. And so here we see a lot more integration of stimuli with response function, because we're getting closer and closer to the diencephalon and the cerebrum. Speaking of diencephalon, what are some of its anatomical features, and most importantly, what does it do? The diencephalon contains the optic tracts. This is what makes sure that visual signals, so light or photons entering the eye, makes it to the posterior aspect of the cerebrum, known as the occipital lobe, for interpretation and analysis, so that we can understand what we are seeing in our field of vision. More on that later on when we talk about the special senses. The diencephalon is also home to the mammillary bodies, and the mammillary bodies are most associated with our ability to store memory as well as respond with certain emotions. The diencephalon will give rise to the thalamus and epithalamus. The epithalamus I highlight because it contains a very important endocrine gland, most responsible for the production and secretion of melatonin we talked about a couple of weeks ago. This is the pineal gland, and the pineal gland is found in the epithalamus of the diencephalon. Diencephalon also has the hypothalamus, which was the grandparent gland regulating homeostasis. The hypothalamus has the capacity to produce and secrete all the hormones that have certain 2 words in it, which I'm going to leave up to you to review because we talked about this 2 weeks ago. The hypothalamus is integrated with the autonomic nervous system. More on that in just a little bit. But the main take-home point here is that homeostasis is very much, we don't think about doing this, right? Our body just knows when it's time for negative feedback mechanism to kick in to maintain balance. It also knows when it's time for positive feedback mechanism to kick in to maintain homeostasis. And so for this reason alone, we deduce that the hypothalamus is very much integrated with the nervous system, specifically the autonomic nervous system. Keep in mind that the hypothalamus has a lot of control over the pituitary gland. The pituitary gland is like a two-in-one. There's an anterior pituitary gland as well as a posterior pituitary gland. And again, I will leave this up to you to review which hormones are produced from which part of the pituitary gland and which ones are stored in the anterior versus posterior pituitary gland. Now, the cerebrum. The cerebrum, here's a cross section. This is in the coronal, also known as the frontal plane. We show this to you because it shows you what's happening, or the structures that are located at the depths most deep to the cerebrum. Really hard to see in any other schematics or other diagrams because we often see this from a superficial view. So to highlight a few things here is the thalamus, as well as the lateral ventricle. Lateral ventricle is what will contain cerebrospinal fluid. All of this is found deep to the temporal lobe, parietal lobe, frontal lobe, as well as the occipital lobe. What I want to bring to your attention, because it's best seen in this view, are structures known as gyri and sulci. And we would be here forever discussing all the different gyri and all the different sulci. This is a topic in of itself. But the main take-home point at this stage is to understand the difference between a gyri and a sulci. Gyri is plural for gyrus, and sulci is plural for sulcus. And so a gyri is going to be any folds found at the surface of the cerebrum. Once again, the gyri is any folds found in the surface of the cerebrum. So here is a really good zoomed up image right here. Now, the gyrus is most superficial. It is the fold, which will then dive deeper into what we know as the sulcus. So the sulcus are the grooves found in between the gyri. In other words, the gyri are like the hills, whereas the sulci are the valleys. The corpus callosum is a really important structure that connects the right hemisphere, so the right half of the brain, so to speak, to the left half of the brain. Damage to the corpus callosum will result in significant incoordination issues in the patient. So here's the corpus callosum represented by this arrow over here. And everything I said in word form for you. The longitudinal fissure I haven't addressed yet, so I will address that now. The longitudinal fissure is a divide between the right and left hemisphere, and it's in the longitudinal plane, also known as more formally known as the sagittal plane, specifically the mid-sagittal plane. If you recall from Bio 201, this longitudinal fissure will separate the two hemispheres from one another. Now, we've talked about the renal cortex versus medulla. We've also talked about the adrenal cortex and adrenal medulla. And so that bring that up now because cortex is a term that we reserve for the most superficial layers of the organ. The brain also has a cortex, and the cortex is only found in the cerebrum of the brain. And so when we revisit the slide here, the cerebral cortex is found most superficial, surrounding the rest of the brain. Surrounding the rest of the brain. So in other words, the region that's colored in a darker brown shade. The cerebral cortex is most concentrated with gray matter, whereas the center portions of the brain are more concentrated with white matter. White matter is typically more rich in the axons, so lots of action potentials and nerve signals traveling through the white matter more so than the gray matter. In the gray matter, the cell soma, or the cell body of the neurons, the functional units of nerve system, are typically found in gray matter. And so we see a lot of cell bodies, nuclei of the neurons found in the cerebral cortex. We will now touch upon the specific functions of the four main lobes of the cerebrum. Again, these are located right next to the cranial bones of the same name. The largest, typically, of the lobes is the frontal lobe, located most anteriorly to the brain. Here, muscle movement is controlled, as well as moods, aggression, smell, and motivation. Motivation is a big take-home point function here. Also, the frontal lobe is most responsible for the human ability to logically think. These are functions that require higher level decision-making capacity. It's what differentiates the human brain from our chimpanzee, monkey counterparts. They don't have as big of a frontal lobe as the human brain. And for this reason, monkeys and chimpanzees, while they very much do a lot of things humans do, they are not able to make higher level decisions. The parietal lobe is most responsible for touch, our ability to sense touch, perceive pain, as well as regulate temperature. We like to ask about the temporal lobe because it's right next to the temporal bone, where the internal acoustic meatus, as well as the inner ear apparatus, is found. The temporal lobe is really important for ability to hear. Last but certainly not least, the occipital lobe is most posterior, and this is the lobe I've mentioned already. This is associated with our ability to interpret our field of vision, and so the word vision here is found right next to the occipital lobe. The cerebellum is the fourth and final parts of the brain we'll discuss today. As mentioned before, the cerebellum is often considered the mini brain, located most posteriorly. What is most unique about the cerebellum is it actually is shaped like a butterfly. Like the cerebrum, it has two hemispheres connected by not a corpus callosum, but a structure known as the vermis. And so the right cerebellum is helpful in controlling coordination in the left side of the body, and vice versa. The right side of the body is controlled by the left hemisphere of the cerebellum. The same applies to the hemispheres of the cerebrum. As mentioned before, the cerebellum is really important in maintaining posture and balance. The cerebellum is actually one of the brain parts that we see degenerating in patients who have Parkinson's disease. More on this when you get to pathophysiology. This concludes the segment of today's presentation with regards to brain anatomy and function. Moving on to the autonomic nervous system. The autonomic nervous system is a division of the peripheral nervous system. Once again, the autonomic nervous system is a division of the peripheral nervous system. There are two parts to it, and a sympathetic as well as a parasympathetic nervous system. The autonomic nervous system I often think of as automatic because it's very much involuntary. And because it's involuntary, the autonomic nervous system is most often in the background regulating functions of internal organs like the lungs, like the heart, like the esophagus, stomach, small intestine, large intestine, and other organs of the digestive system. These organs and systems keep working without us telling it to. And we attribute a lot of this to the autonomic nervous system. Because of its role, the autonomic nervous system is heavily important in regulating homeostasis functions. And so that's why when we talked about the endocrine system, there was a lot of intersecting and a lot of intersection between the endocrine as well as the autonomic nervous system. We saw this with the hypothalamus. We also saw this with the adrenal glands, specifically the adrenal medulla. And again, this is going to be one of those moments where I say it will be good review of the endocrine system for you to revisit all of that. Now, homeostasis is really key for maintaining overall health. And so the autonomic nervous system is really helpful in helping us deal with emergency situations, such that when we are in the classic fight or flight scenario. So in a lot of the literature and textbooks, we define the scenario, the vignette as, we describe the scenario, in this case vignette as, you find yourself in front of a tiger and you don't stand there and think, or at least I hope you don't stand there and think, should I fight you or should I run away from you? You just do one of those things because you don't have all the time in the world to figure out how to save your life. This automatic, almost immediate response to run away or fight this tiger is driven by the autonomic nervous system, specifically the sympathetic subdivision of the autonomic nervous system. And so the sympathetic subdivision is what will ramp up to give you energy when there's a stressful situation, like being faced, like facing a tiger. And there will be physiological changes that occur to help you fight this thing or run away from this thing. These physiological functions include an increased heartbeat, because in order for your muscles to contract and relax, they're going to need lots of oxygen. And the only way they're going to get lots of oxygen is if your heart is beating a little faster to keep up with the supply and demand, to keep up with the demand that these muscles are going to require of oxygen. Now, because the heart simply just moves oxygen, we have to bring oxygen into the body by way of the lungs in the first place. And so part of the sympathetic physiological response is an increase in breathing rate. There are neurotransmitters, specific ones that drive this sympathetic response. These are acetylcholine and norepinephrine, also known as noradrenaline. Adrenaline, epinephrine are synonymous. And adrenaline and epinephrine are what's most telltale of a sympathetic nervous system response. So let's talk about an emergency situation, a clinical situation in which this is helpful to know. So we are going to paint the case of an anaphylactic reaction. There was a 5-year-old that had no idea they were allergic to nuts, or maybe they did, but they didn't know because they just wanted to eat the yummy snack. And so within seconds, this patient is breaking out in hives, lots of itching, lots of redness, lots of swelling, but most concerningly, his or her throat is swelling so much they are having a hard time breathing. Now, this would be an opportune time to apply that EpiPen, because what EpiPen is adrenaline, also known as epinephrine. What we're essentially doing when we apply the EpiPen, or when we administer the EpiPen, is we are ramping up sympathetic nervous system activity, because we know that sympathetic nervous system activity will increase heartbeat and increase heart rate in response to this stressful situation. So we are essentially helping this patient breathe even just a little bit until we get them to a setting wherein we can intervene with more long-term solutions. In contrast to sympathetic nervous system activity is parasympathetic nervous system activity. This is what I often associate with the rest and digest, because this is the part of the autonomic nervous system that drives the ability for a digestive system to work well as other functions that we would want to take advantage of when we are not in a stressful situation, when we are not in front of that tiger. So these are processes like urination and defecation, more colloquially known as taking a poop. So let's think about this for a second. When you are in front of a tiger, any urge to have a bowel movement, to defecate, or any urge to urinate goes away pretty much instantly, because your body's priorities have changed in a matter of seconds. It doesn't matter whether or not you're going to pee your pants or poop your pants or not, if you are not alive, because you did not survive this pending attack that you have with this tiger. So parasympathetic nervous system activity is typically regulated by the acetylcholine neurotransmitter. Once again, the acetylcholine neurotransmitter. What's interesting about acetylcholine is it's pretty much the main neurotransmitter. You'll see it in almost every aspect of the nervous system. And so in many ways, the parasympathetic part of the parasympathetic aspect, the parasympathetic state, the rest and digest state, is, in terms of neurology, considered the default state. And so any stressors will put your body into a sympathetic drive. And if the body cannot push itself out of a sympathetic drive, then this is what leads to chronic fatigue issues and dysregulation of the nervous system in the long run. If you have more questions about this, I'm happy to chat with you one-on-one, but I thought I'd just mention it because it's something that we're seeing a lot in our patients, especially because we live in a world where it's just really difficult to disconnect, right? To disconnect from work, to disconnect from society, when we all need that every once in a while. And so we find ourselves in a perpetually stressed state. So this is the dichotomy between the parasympathetic and sympathetic state, both of which are part of the autonomic nervous system. I will move on now to the 12 pairs of cranial nerves. This is one of those topics where we can have an entire lecture focused on, but we don't have that kind of time. And the main point here is for you to understand, be familiar with these 12 cranial nerves. So there are 12 pairs of cranial nerves, meaning there is a right and a left of each pair, for a total of 24 cranial nerves. So that's something that I would keep in mind, because this is often what gets students. There are 12 pairs. There are 2 in a pair. So if you're asked for how many cranial nerves there are in total in the body, you have to do some math. So 12 times 2 makes for a total of 24 cranial nerves in the body. Each cranial nerve has a Roman numeral, and it's got to be written in Roman numerals. If you need a crash course in Roman numerals, let me know, and I can give you a crash course in less than 10 seconds. You are responsible for both the Roman numeral as well as its English name, as well as, of course, what it does. So we'll go through these together now. Cranial nerve number 1 is sensory only. It's most responsible for our sense of smell. This is known as the olfactory nerve. Cranial nerve number 2 is the optic nerve, most responsible for our sense of sight, our ability to see. So olfaction is what we refer to as the sense of smell. Optic, anything that has the prefix opt, like optometry, ophthalmology, has to do with the eye. This often confuses students because they're the first 2, they come right after the other, and they both happen to start with the letter O. So what helped me a lot when I was in grad school is you only have one nose, which is responsible for our sense of smell. So that's cranial nerve number 1 for one nose. But you have 2 eyes. Cranial nerve number 2 is responsible for our sense of sight. The optic nerve got 2 eyes. So cranial nerve number 2 has to do with our ability to see. This brings us to cranial nerves 3, 4, and 6. I'm going to look at these together because 3, 4, and 6, the oculomotor, trochlear, and abducens nerve, have to do with moving the eyeball. There are muscles that surround the eyeball that help move our eyes in an up, down, left, right movement. They're also responsible for rolling our eyes, like when our friend says something silly. These muscles are governed by cranial nerves 3, 4, and 6. Oculomotor nerve, cranial nerve number 3, is also responsible for the pupillary reflex. So when light is shown into the pupil, what we hope we see is that reflex constriction of the pupil. The pupil will get smaller. It's a test that we do, especially in critical care, to determine to triage the patient. The cranial nerves 3, 4, and 6 is basically what we're testing when we have a patient follow our fingers with their eyes, not their neck. Otherwise, we're not really testing the muscles that move the eyeball. Cranial nerve number 5 is the trigeminal nerve. What's most unique about the trigeminal nerve is that it has the prefix tri to indicate 3 branches of this nerve. It is the only cranial nerve that has 3 branches. The trigeminal nerve is responsible for our ability to chew, so mastication. It's also responsible for our ability for our face to sense touch. Cranial nerve number 7 is the facial nerve. It's responsible for helping us smile, frown, look confused. because it's responsible for facial expression. It's also responsible for taste, along with cranial nerve number 9, the glossopharyngeal nerve. More on that on the next slide. The cranial nerve number 8 is the vestibulocochlear nerve. That one's a mouthful. So once again, the vestibulocochlear nerve. It is responsible for our sense of hearing as well as our sense of balance, more formally known as equilibrium. And it has a lot to do with what's going on in the inner ear. I will show you in a slide later on. Cranial nerve number 9, I've already mentioned, is involved in our sense of taste, but it's also involved in the movement of swallowing. Cranial nerve number 10, the vagus nerve, is responsible for a lot. I could do an entire lecture just on the vagus nerve because of how much it does. Some take-home points here are that the vagus nerve is actually the longest cranial nerve. It stems from the brainstem and goes all the way to the heart as well as the digestive system. The vagus nerve, once again, is the longest cranial nerve. It helps regulate digestive function. It also helps regulate how slow the heart beats, among other physiological processes. Cranial nerve number 11 is the accessory, also known as the accessory spinal nerve. This nerve is motor only. It moves the sternum, certain muscles that move the neck. It also moves the trapezius muscle. It's also involved in swallowing as well as head movement because it controls the rotation of the neck by way of the sternocleidomastoid, that really important neck muscle that pops up when you turn left, you turn your head left in left lateral rotation and in right rotation. Cranial nerve number 12 is the last cranial nerve. It's the hypoglossal nerve, responsible for moving our tongue, and for this reason, responsible for our ability to speak. In this last segment, we discuss the special senses. The special senses are what we often refer to as the 5 senses: our ability to smell, sense of smell, sense of taste, sense of hearing, sense of seeing, and sense of touch. The latter we will not discuss today. We begin with the sense of smell. So, how this is mediated by cranial nerve number 1, the olfactory nerve. How this works is, here is a lateral view in the sagittal plane of the nasal cavity. This is the nose, here's the nasal cavity, and this is the nasopharyngeal space. To give you the lay of the land, this is the hard palate, here's the soft palate. Anything inferior to the soft palate or uvula is already oropharynx, located behind the oral cavity. When air enters the nasal vestibule by way of the nostrils, also known as the external nares, it will encounter a specific type of sensory receptor known as the receptors of the olfactory nerve. They're located here at the most superior aspect of the nasal cavity. Here, the sensory receptors convert chemicals into an action potential. This sensory receptor is often classified as a chemoreceptor because it converts a chemical stimuli into a nerve signal, which is then what will be sent to the brain for interpretation and analysis. Sense of taste is first, it begins with the taste buds or papillae on the tongue.
You may be well aware that there are several types of taste buds. Some regulate sensing sour, some salty, and so on and so forth. The papillae or taste buds are located in specific aspects, specific areas of the tongue. Here is a bird's eye view of the tongue right here, and here is a close-up, zoomed up version of the tongue so you could see the taste buds. The taste buds are also chemoreceptors. They convert a chemical stimuli in the form of food into a nerve signal, which is then what will travel through two specific cranial nerves. These are cranial nerve 7, the facial nerve, and cranial nerve number 9, the glossopharyngeal nerve. These chemoreceptor sensory nerves will transmit the signal to the brain so that we can understand what we are tasting in our food. Taste is influenced by olfactory sensations. I won't go into the nitty-gritty of it now, but I will explain why this is important. There's a saying that goes, taste is half smell. And if you've ever experienced a severe case of sinus congestion, you may find that your things taste different, or you may not taste at all. This hits close to home for many because one of the symptoms of a COVID-19 infection, and something that I'm seeing a lot in our patients who are experiencing long haul COVID or COVID long haulers. They're still experiencing symptoms, even though it's been many months since the initial inoculation, the initial infection. They still have not gotten their sense of taste or smell back. And what question I'm often asked is, well, will I get one back or will they come back together? And the answer I typically give my patients is, well, everybody's different, of course, but based on what I know about anatomy and physiology, it's that I expect that they will come back together or soon after one another, because taste is heavily influenced by the sense of smell. Let's move on to the sense of sight. So again, as review, this is mediated by cranial nerve number 2, the optic nerve. The optic nerve is a photoreceptor. So how this works is, here's the pupil and here's the lens. Light enters through the pupil and the lens will move in such a way so that light will hit the back of the retina where the photoreceptors are. Their photoreceptors are what will convert that light signal, these photons, into a nerve signal, which will then travel through the optic nerve to the occipital lobe of the brain for interpretation and analysis. So there is quite a bit of physics that we don't get into in today's lecture because we simply don't have the time. Many of us wear corrective lenses, and so to illustrate and demonstrate the role of corrective lenses, it basically picks up where the natural lens of the eye has left off. When we talk about myopia, or close-sightedness, nearsightedness, and farsightedness, the lens has lost its ability to move in such a way, move optimally, so that when light enters the eye, it hits the proper places of the retina. And so a lot of light signal is lost because of this, and so a lot of light signal is not converted into that nerve signal we need for the optic nerve to bring that signal to the back of the brain, the occipital lobe, for interpretation and analysis.
And so there's a theme here. Here's a close-up of the photoreceptor network. The theme here is that if the sensory receptor is not able to convert that stimuli, whether it's a chemical, whether it's a light signal, and what we'll talk about next is hearing equilibrium. So if it's the sensory receptor is not able to detect the sound wave, and it cannot convert that signal into a nerve signal in the form of an action potential, recall that the central nervous system only speaks one language, and that is that of the action potential, a nerve signal. If there is no nerve signal traveling through the nervous system, specifically to the brain or spinal cord, as far as the central nervous system is concerned, there's nothing happening in the environment. And this is at the root of many nervous system issues where a patient is unable to detect what is going on in their environment. With that being said, let's talk about the sense of hearing and equilibrium. This is like a 2-in-1. It is governed by cranial nerve number 8, the vestibulocochlear nerve. The ear apparatus is quite involved. There's an outer ear, a middle ear, and an inner ear. The outer ear and middle ear is most responsible for making sure that sound signal moves from the external environment and towards the inner ear, where the vestibulocochlear nerve is found. So the outer ear is marked by the pinna, the part of the ear that we can't see on many patients. At the center is an opening called the external acoustic meatus, which provides the opening for this auditory canal. This canal will deliver sound waves from the external environment and bring it towards the middle ear and then the inner ear. What marks the middle ear is the very popular eardrum, more formally known as the tympanic membrane. There are 3 small bones known as the auditory ossicles. They are, fun fact, the smallest bones in the body. They're known as the malleus, incus, and stapes. They will carry sound waves from the external ear through the middle ear and into the inner ear. Here's a close-up of the malleus, incus, and stapes. Sound travels best in solid medium. This is why if you were to hear some chatter in the room next door, you'll be able to hear it more clearly if you were to place your ear right against the wall, because you'll be able to pick up sound signal that's traveling through a solid medium, and it travels faster in solid medium, more so than liquid medium, less so in gas medium like air. So the malleus, incus, and stapes are all bone, right? Bone is certainly matter that we can see. It's mass that you can see. It is in a solid state. And so the very fact that the middle ear is comprised of bone helps make sure that there is fast transmission, fast transfer of sound waves from the outer ear and into the inner ear. Also found in the middle ear is the eustachian tube. We forget it's there until we are descending from higher elevation, whether this be coming down the I-17 from Flagstaff or descending from high elevation in an airplane. You may recall or remember a time where there was a lot of pressure, felt like there was a lot of pressure buildup in your ear, and you do all that you can, chew gum to make your ears, quote unquote, pop. The eustachian tube is the culprit in that scenario. The eustachian tube connects the middle ear, right here, the middle ear to the oral cavity, which is why anything that you can do to move or depressurize, move the eustachian tube so that it can have an easier time releasing extra pressure, like chewing gum, like drinking water, and for infants, like giving them a feeding bottle. This will help release that extra pressure and provide relief to the middle ear so that it doesn't feel as pressurized. This brings us to the inner ear. The inner ear has two regions. There's a cochlea, most responsible for hearing, and the vestibule. The vestibule is home to three semicircular canals. There are three semicircular canals, one for each plane of the body. And so the fluid that's traveling through the semicircular canals gives our body a sense of balance, a sense of equilibrium. This shell-like structure here marks the cochlea. The cochlea is where the sensory receptors for sound waves, they convert sound waves into an action potential, aka a nerve signal, which the vestibulocochlear nerve will carry to the brain for interpretation and analysis. So the inner ear is a two-in-one. There is a region responsible for our sense of balance, and there's a region that's responsible for our sense of hearing. It's known as the vestibular cochlear nerve for a reason, because it collects signal from the vestibule as well as the cochlea. Now that we've discussed the contents of the inner ear, we can better appreciate and understand why patients who struggle with hearing are more prone to losing their balance and are more prone to falls. This is most concerning. This is of increased concern for our patients, for our senior patients, because they're more prone to hearing loss as well as more prone to losing their balance. The vice versa is true. Patients who have a harder time balancing often also have a harder time hearing. This concludes the content that I would like to discuss for chapter 11. Here is a summary, useful review tool for you. If you have any further questions, don't hesitate to reach out. I hope you found this video very helpful. Until next time.